Hi, my name is Sal Mandalaoui and I'm an MD2 student here at Windsor. Today, I'll be discussing a case study involving a 30-year-old male patient and explain my in-depth analysis. First, I'll be talking about the kidney's relations and clinical significance. The kidneys regulate blood pressure, filter, and excrete waste to prevent conditions like proteinuria, hypertension, and hematuria. In this case, the patient presented with hypertension, which disrupted blood flow in the renal arteries. Studies show that diseases affecting the renal hilum, which is a key entry point for nerves and vessels, can cause hematuria and proteinuria. The presence of red blood cell casts and dysmorphic red blood cells in the urine suggests damage to the kidney's internal structures, such as the glomerulus, impairing its ability to properly filter blood. It's likely that this patient is suffering from a glomerular disorder that's impacting both their blood pressure and fluid balance. Now talking about the nephron's histology and clinical significance. The patient's proteinuria, hematuria, and renal impairment indicate complications in the neuron's ability to filter blood through the glomerulus. The red blood cell cast suggests possible damage to the proximal tubule, impeding the reabsorption of glucose, water, and electrolytes. Disruption of the loop of Henle could also contribute to a water electrolyte imbalance, worsening the patient's hypertension. The nephron's histology explains the patient's hematuria, proteinuria, and red blood cell cast, indicating significant disruption in the glomerular filtration barrier. Now, when talking about development of the nephrons and derivatives of the mesonephric duct, we'll start with the disruptions. And one of the disruptions in the nephrons and mesonephric duct can lead to congenital or acquired renal pathologies. See, during fetal development, the metanephros give rise to the nephrons. And the patient's hematuria and proteinuria could indicate abnormal nephron development or later acquired damage. Now, the mesonephric duct forms the ureter, vas deferens, and seminal vesicles, which are essential for renal function. Furthermore, embryonic tissues from the glomerular basement membrane are also formed by the mesonephric duct, and they act as a barrier in blood filtration. This patient's nephritic syndrome suggests immune-mediated glomerular damage, explaining both congenital and acquired renal pathologies seen in this patient's hematuria and glomerular damage. Now we'll talk about the kidney's role in blood pressure regulation. See, this patient's hypertension indicates that their kidneys failed to regulate blood pressure through the renin-angiotensin-aldosterone system. This is a system that responds to hypotension by releasing renin from the kidneys, which then cleaves angiotensinogen existing in the body to angiotensin 1, which then, along with ACE from the lungs, is then converted to angiotensin 2. Angiotensin 2 stimulates the release of aldosterone from the adrenal cortex, which promotes sodium retention, but again, angiotensin 2 itself then causes vasoconstriction. Now, when correlating this to renal dysfunction, ultimately, the renin-angiotensin-aldosterone system's activation is meant to raise blood pressure and promote sodium retention. Like I said before, failure of this patient's kidneys to regulate fluid balance is what contributed to his elevated blood pressure. It caused excess sodium retention and water retention. Proteinuria and red blood cell cast further contributed to his high blood pressure, impairing glomerular filtration and forcing the body to maintain renal perfusion. Thus, the patient's at risk for both renal and cardiovascular complications due to the renal dysfunction, which is likely the cause of their hypertension. Now, there's two genetic conditions with hyperuricemia that I'll talk about. And complications in period metabolism in patients with genetic disorders can lead to hyperuricemia. So when talking about HGPRT deficiency in Leigh-Schneiden syndrome, it causes hyperuricemia and gout because of excess uric acid production. But now in Kelly-Siegmiller syndrome, there's partial HGPRT deficiency in these patients, and it can lead to hyperuricemia and also gout and kidney stones. Now we'll talk about hepatic encephalopathy. This one's very important. Now, liver dysfunction can lead to hepatic encephalopathy by impairing the liver's ability to convert ammonia to urea for excretion in the urea cycle. Now, the pathogenesis of hepatic encephalopathy is that ammonia is built up in the bloodstream due to this impaired detoxification. That ammonia can cross the blood-brain barrier and lead to neurological effects. Now, in the general presentation of urea cycle disorders, patients present with various symptoms, including hyperammonemia, neurological issues, and developmental delays. Patients seen when this cycle fails to convert ammonia to urea. Patients with these defects, having prevented conversion of ammonia to urea for excretion, present with lethargy, vomiting, seizures, and, like I said before, developmental delays. Now, the unique clinical differentiations start with protein intake in patients with them can cause an OTC deficiency, leading to respiratory alkalosis, hyperammonemia, and altered mental status. Clinicians can differentiate unique clinical differentiations from arginose sucrate lyase deficiency by looking for hyperammonemia, hepatomegaly, and brittle hair. In conclusion, the patient in this case study suffers from multiple renal disorders that require urgent attention. First, kidney dysfunction is evident through hypertension, hematuria, and proteinuria. Secondly, defective purine metabolism could be causing hyperuricemia. And lastly, ammonia buildup may explain signs of hepatic encephalopathy. Clinicians should thoroughly investigate potential urea cycle disorders that may lead to neurological and developmental complications. Thank you for watching, and I'll see you next time.